Greetings everyone, I hope you're all having a very good day. My name is Dr. Samira Mirzapur, periodontist. In this video, I want to compare these four techniques together: deep margin elevation or DME, surgical crown lengthening or CL, forced eruption or orthodontic extrusion, and biological shaping or BS. These four techniques are used to manage deep subgingival margins when we have deep caries or deep fractures in the subgingival area. Each has its indications, advantages, and limitations, which we want to compare in this video. DME or deep margin elevation was first proposed in 1998 by Dr. Dietzke and Esprefico. It is also known as cervical margin relocation or proximal box elevation or coronal margin relocation. It's a procedure which is used to raise or reposition subgingival margins and convert them into supragingival margins, which can be used for direct or indirect restorations. Its forerunner was the open sandwich technique, which was used traditionally with a glass ionomer to fill the cervical part of the proximal box. In this photo, you can see the closed sandwich and open sandwich technique, which uses resin-modified glass ionomer in the base of the proximal cavity, and then the flowable composite, and then the main composite was formed in the occlusal area. But studies have shown that glass ionomer is not the best material for deep margin areas because it has weak mechanical properties. It is bad for flexion and strength, it can dissolve quickly, it is not easy to manipulate, and under occlusal loading it can fail. So with the development of different composite materials, nowadays DME has re-emerged as an innovative technique. But the core principle here is that if you cannot isolate the tooth, then DME is contraindicated. Rubber dam isolation is extremely critical because we're working in an area that contains GCF, gingival curvicular fluid, and most likely gingival inflammation, which is prone to bleeding. And there are different matrix which can be used to help us in the DME techniques, such as Real Matrix by Garrison. The person who is performing the DME needs to be very skilled because it's a very technique sensitive procedure. So the person should be able to isolate perfectly with the rubber dam and form the proximal area with the matrix without producing any overhangs. So how much the caries can be subgingival for deep margin elevation to be performed? The caries can be subgingival but limited to the junctional epithelium. If the caries or the fracture has extended to the connective tissue attachment area, then DME cannot be performed without CL surgery. So the margin of the restoration needs to have a proper distance of about 1 to 1.5 millimeter, or in some articles 2 millimeter from the alveolar crest. There are different techniques you can use, such as the MIM technique, to perform the shaping of the interproximal area. It's a technique which was presented to facilitate isolation of deep subgingival margins in Class 2 preparation, which uses a modified circumferential matrix band, which is added inside the modified circumferential band. The sectional matrix is added, and Teflon tape or PTFE tape is packed apically between the two matrices. Of course, many different techniques can be used, and MIM technique is just one of them. I think DME is pretty beneficial, especially in teeth having caries adjacent to dental implants, which is also famous to dental implant induced caries. Due to interproximal contact loss, the pattern of caries occurs on a tooth adjacent to an implant along the root surface, so it can extend apically. And in these areas, crown lengthening surgery is a bit challenging because we don't want to manipulate the bone around the implant too much. So DME can be pretty beneficial, but provided that you have 1 to 2 millimeter distance with the alveolar crest for the connective tissue fibers. And the modified Toffelmayer matrix band could be used for better adaptation and deep sulcular seating for the DME to be achieved. DME can be indicated for severely damaged teeth where, due to financial reasons, the patient cannot choose a more definitive option such as an implant or CL and post-core crown. So, in the worst case scenario, DME acts as a long-term temporary restoration. This is the exact term that has been used in some articles, a long-term temporary restoration. So it's not too bad. So when can we use the deep margin elevation technique? When caries invade the gingival sulcus, but they are within the junctional epithelium, and they are not inside the connective tissue attachment. And we should have the distance from the alveolar bone, which is about 2 millimeter. Biological widths, which is today called STA or supracrestal tissue attachment, is said to be 2 millimeters, but we know that in different patients it can be 1 to 9 millimeters. But this variation in the STA is caused by the junctional epithelium, and the connective tissue part of the biological width is almost constant in all the patients. It's about 1 millimeter or 1.5 millimeter. So when you have that distance from the bone, which is almost the same in all patients, DME is okay to be done in a patient who has good oral hygiene with periodic dental visits. But is it completely safe? No, there are some risks associated with DME. As I said earlier, it is pretty technique sensitive and it needs to be done by a pretty skilled restorative dentist. And there are some problems in the cervical margin. In the cervical area, there's usually no enamel, which is a weak area for bonding the composite restoration. And if there is an enamel, it is usually thin and it is less structurally organized compared to the enamel in other regions of the tooth. So it is resistant to acid etching. And because we need more composite, shrinkage stress can be induced and cause gap and pore seal in the area. And when a gap is produced in the deep interproximal area, it can cause post-op sensitivity if the tooth is vital, or it can cause secondary caries and periodontal problems because there's bacterial leakage there. And also DME, if it's not done correctly, it can produce an overhang or the surface roughness of the restorative material can cause periodontal problems. So it is technique sensitive. That's the most important thing about DME. Most studies have reported that in the case of deep margins invading 2 millimeter from the bone crest, CL is surely necessary. So you cannot place your matrix inside the connective tissue space. And CL would be necessary prior to DME or routine restorative techniques. Toleration of DME has been shown in different articles by the periodontium, and it is said that after DME, a different kind of biological width is created, which is also healthy, but it has a longer junctional epithelium and a smaller connective tissue attachment, and the epithelial fibers have the ability to bind to the surface of the resin restoration. The second technique that we can use and is traditionally used is crown lengthening or CL surgery. Its core principle is biological width, as I'm sure you know, which is also called supracrestal tissue attachment, and it is consisted of the epithelial attachment and the connective tissue attachment. If you do not do CL, in these cases, gingival inflammation, bone loss, and attachment loss will proceed. In this case, you can see that the CL is performed for this tooth. In this systematic review, CL is compared with deep margin elevation, And the authors reached to the conclusion that within the limited available evidence, CL is successful for long-term retention of teeth, but deep margin elevation has a better survival ratio. What does this mean? This statement suggests that while CL can help retain teeth over time, DME results in a better overall survival rate. Why? Because with DME you avoid complications such as increased crown-to-root ratio, bone loss, and post-surgical recession, which could occur after CL in patients that have a thin periodontium. The third option that we can use is orthodontic forced eruption or extrusion. It is usually done in anterior regions, in one-rooted teeth, in aesthetic zones, in patients that are young, for example in teenagers and the young adults, where we don't want to extract the tooth because we cannot place the implant because the patient hasn't reached 18 yet, or CL would cause unpleasant aesthetics, or CL can remove the gingiva and bone in the adjacent teeth, which could cause aesthetic and biological problems such as caries or mobility. So orthodontic extrusion or forced eruption could be a viable option in these patients. In this technique, bone and gingiva move chronally with the tooth, and so it maintains the periodontal support. But of course it would take longer. The tooth can be extruded about 1 millimeter a week, but retention time is also necessary to prevent relapse, and if the orthodontic extrusion is not done correctly, there is risk for root resorption. In this picture you can see that the crown to root ratio is compared between CL and forced eruption technique. After CL, the crown to root ratio is about 5:4, but after forced eruption it is 4:4. So it increases, but not as much as CL. To prevent relapse after forced eruption, we can use CSF or circumferential supracrestal fibrotomy during the orthodontic extrusion. In this technique, every 1 to 2 weeks, we sever the periodontal fibers in the sulcus area with a blade, which is pretty simple to do, just a little anesthetic, and you sever the transeptal and circular fibers. And this technique can increase the speed of the orthodontic extrusion and reduce the risk of relapse and reduce the need for CL after the forced eruption technique. But sometimes, or I think most times, even after forced eruption, CL is again necessary to prevent the coronal migration. So usually after completion of the forced eruption, we still need to do a CL surgery, but this time CL is very conservative, very minimally invasive, just to improve the aesthetics and remove the bone and the gingiva that have moved coronally. The last technique that I want to discuss is biological shaping. This technique was introduced by Dr. Melker in 2001. In this article, it was previously called root reshaping. In this technique, which is similar to CL, so it's kind of a periodontal surgery, but there is not much need for removing the bone. So sometimes there's no need to remove the supporting bone, or even if you need to remove the bone, it's pretty minimal. So how does this work? By reshaping the root of the tooth, we move the margin away from the bone, and we also eliminate the forcation lips, the forcation areas. In this article in 2024, this technique is revisited as biological shaping. In the authors, you can see again the name of Dr. Daniel Melker and Dr. Homley Wang. Biological shaping, or BS, begins with the removal of any existing carious lesions, restoration, crowns, or bridges. As you can see in the photo, we remove the old crowns, all the caries, and then the restorative dentist places a solid bonded resin foundation and prepares a feather edge margin on the tooth for an interim crown. This interim crown is necessary in the BS technique. The margins should be kept 0.5 to 1 millimeter away from the gingival margin, so the margins are supragingival. Here in this photo you can see that the solid bonded resin or the resin cores have been prepared, and the provisional crown is delivered to the patient. On the day of the surgery, the periodontist removes the provisional crown and reflects a full thickness flap to perform osseous contouring 360 degrees on the buccal and lingual sides. But first, before we do the osseous contouring, first we remove the granulation tissues and we reshape the root. So we remove the margin that the prosthodontist had prepared, and we smooth the tooth. We remove the concavities, the root concavities, the developmental grooves, the bone exostoses, the forcation lips, and then we reassess the tooth. Do we have enough distance with the bone? If yes, there's no need for bone removal. If not, there's only need for minimal bone removal. After that, you suture the area and we send the patient to the restorative dentist. The restorative dentist needs to alter the interim restoration a bit to place the margins more supragingival, 1 to 2 millimeters supragingival, to help reestablish a healthy supracrestal tissue attachment. So the margins are more supragingival. We give space for the gingiva to reform, to reestablish, to become more thick, which is the core principle here. And after 14 weeks or 4 months, the final restorations are delivered. Here in this photo, you can see that the final restorations are also different. They should be designed in a way that the patient has access for optimal oral hygiene. You need to be able to insert a periodontal probe at the forcation bone level, and the area should be completely smooth. There should be no undercuts, no over-contour areas, so that the patient can clean the proximal and the forcation areas. In this photo, you can see how the biological shaping or the root reshaping technique moves the forcation area away from the bone, moves the margins away from the bone, because it makes the tooth a little narrower. The things that are very important is that challenging to deep clean grooves should be removed, and the final restoration shouldn't have height of contour. The forcation should be formed in a barreled shape so that the patient can clean the area, and it should be completely smooth from the bone up to the occlusal surface. So this technique moves the finish line away from the bone and thickens that connective tissue barrier because the margins are pretty supragingival. This is the core principle of BS technique. In this photo, you can see the same technique has done for this premolar and molar in the mandible area. If you have some problems with the metal show in the forcation area, you can use zirconia for better aesthetics, but the area should be completely barreled so that the patient can clean the area. In this table, you can see that the functional crown lengthening or FCL is compared with biological shaping or root reshaping, the BS technique. In the CL, we need to remove 3 to 4 millimeters of bone, but in the BS technique, the bone is preserved or it is removed very minimally. Crown to root ratio is not increased much in the BS technique. The bone is slightly removed. Root reshaping is the core principle of BS technique, but such a thing is not done in the FCL. Provisional crown is not necessary in the traditional CL, but in the biological shaping technique, provisional crowns are mandatory pre-surgically. The bone is preserved in the forcation area. In the BS technique, wound dressing is not necessary. Actually, the margins are supragingival to be formed, but in the CL technique, we want to apically push the margins to prevent relapse. But the opposite is done in the BS technique. The keratinized gingiva is preserved, even increased. Not in the sense that it is increased occluso-apically, but is increased in thickness. And the cleansability is better maintained in the BS technique. However, all these techniques that are mentioned are for teeth that can be preserved. If the teeth needs to be extracted, you should not hesitate, and you should extract and use a dental implant, that's for sure. No questions asked. In this table, these 4 techniques have been compared. As you can see, DME is usually indicated in the proximal areas in the posterior teeth when the caries is within the junctional epithelium and it is not violated the biological area of the connective tissue. CL is done if there is a biological width violation. Forced eruption is done in the aesthetic area in younger patients, but it is time consuming. And biological shaping is a minimally invasive surgery performed with the help of a skilled prosthodontist and a skilled lab technician for sure. So I think the biological shaping and deep margin elevation techniques are very technique sensitive both. CL can be done in combination with these techniques as well. CL can be done before DME. CL can be done after forced eruption. And biological shaping is a modification of the CL surgery, I think. So for posterior teeth with deep margins, we use DME. For anterior teeth, forced eruption is usually used to preserve aesthetics. If there is severe biological width violation, crown lengthening is a definitive solution. And if with some minor root reshaping, you can prevent significant bone removal, of course, biological shaping can be used. Here are the references that I used. These 4 articles that have been used and inspired me to make this presentation. I'd be more than happy if you could share your experiences, your comments in the comment section, and don't forget to like this video and subscribe to my channel and follow me. Thanks.